Hello and welcome back to the second day of this conference run by the International Institute for Psychiatric Drug Withdrawal. My name is Stevie Lewis and I am a member of the board. And I'm so pleased to see you back here, and as a member of the IIPDW, I'm very much hoping that yesterday each of you heard something, saw something, felt something that touched you or made a difference to you in some way. There are two things that I'd like to say about yesterday, if you would indulge me for a moment before I formally introduce our first speaker of the day. The first is that society wants us to believe that some of us will be a better version of ourselves if we swallow one or more drugs a day. Yesterday, Robert Whittaker showed us that research demonstrates that this is simply not true. Our potential as human beings is far greater without the pills, and I found that so empowering to hear, and I hope you did too. And the second thing I wanted to say is that I saw from the chat that there are a lot of you out there who are struggling with withdrawal, and I want to speak directly to you. I'm conscious of the fact that what we are saying here is how bad withdrawal can be for some people and how long it can take some people to get through it. And in fact, Mark and I spent 50 minutes on a video last night saying exactly that. And I quite understand that you don't want to know that. I wouldn't have wanted to know that. But it's the truth. And let's face it, if withdrawal were a walk in the park, there'd be no need for this conference. Please believe me, you will get better. I got better. Laura Delano yesterday described how she got better. We're both work in progress, but we are leading good lives. In the darkest times, you don't believe it's going to happen to you, but it does. I would hear that someone had been through their withdrawal, they got better, and I'd have this whiny voice in my head going, oh, they've got better, but I won't. I'm going to be this ill now forever. But the body heals. It does what it's good at. And irrespective of the whiny voice, my body healed. You will get through this. Shall we move on now to the business of the day? Some housekeeping to start. This conference is being recorded, and the recordings will be made available by email on Monday, available for 2 weeks. This afternoon, after we've heard all of the speakers, we will invite you to join us for a group discussion, and this will take place in a separate Zoom meeting, and Lucy is posting the link in the chat now. And the password for this meeting is withdrawal. And Lucy will also send this link via email 10 minutes before the end of the speaker sessions. In the discussion group, you will have the opportunity to have your say about how things on this subject could change for the better. And I need to just add again that closed captions are available. They're in English. We don't think they're that effective, but they are there. So it's time now for another inspirational speaker. Dr. Joanna Moncrief is Professor of Critical and Social Psychiatry at UCL and is a practicing NHS consultant psychiatrist in London. She is a co-chairperson and one of the founders of the Critical Psychiatry Network, and she has written various books and papers, including a book called The Myth of the Chemical Cure, which is the subject of her talk today. If you want to know anything about psychiatric drugs and what they do to the human body, Joanna is the person to ask. We have time for 10 minutes of questions at the end. Please use the Q&A box. But now I will pass you over to Joanna. Welcome, Joanna.
Thank you, Stevie. Thanks for that introduction. Right, I shall crack straight on. I'm just going to share my screen. There we are. Can everyone see that? Stevie nodded, if that's okay, is it? Yeah, great. Okay, thank you. Okay, so thank you very much for inviting me to speak. We're here today because thousands and thousands of people have had difficulties coming off drugs prescribed for psychiatric problems. And the most tragic thing about this is we have been here before, as I'm sure many of you are well aware. The barbiturates, which were hugely prescribed in the 1950s, in the mid-20th century, turned out to be severely dependence forming, and then the benzodiazepines, of course. And we've even known since the late 80s and early 1990s that people can have real difficulties, sometimes very prolonged difficulties, getting off some of these drugs, since Heather Ashton described the problems with benzodiazepine withdrawal. So first of all, I'm going to describe a bit of context, and then I'm going to come on to a few words about withdrawal. And because I know that you covered a lot of ground yesterday, I'm going to focus mainly on withdrawal from antipsychotics and lithium. So first, the context, and forgive me again if this has come up before, but I think it's so important to know how many people are using these drugs at the moment. 17% of the population of England, almost 1 in 5 people, is currently prescribed an antidepressant. And that has increased, the volume of antidepressant prescribing has gone up almost 4 times in the last 20 years. 1 in 4 of the population, 26%, are taking either an antidepressant or a benzodiazepine or a Z drug, a gabapentinoid, or an opioid drug. These are figures from the Public Health England report published in 2018. And is this vast amount of prescribing doing any good? Well, I know you heard quite a lot on that from Robert Whittaker. I just want to add to what he showed you some data from England disability benefits, which shows you that claims for disability for mental disorders, which are predominantly made because of anxiety or depressive disorders, have gone up substantially over the last 20 years, while claims for everything else have come down. And it's claims for long-term claims that have particularly gone up among people who are claiming because of mental health problems. And again, long-term claims for other conditions have actually been coming down. And I know Bob showed you a lot of the studies on long-term outcomes of antidepressant use. I just want to add this one. This is the STAR-D study, which looked at gold standard, really good quality antidepressant treatment in the US back in the noughties, and it was a huge study, enrolled 4,000 people. The results were very much spun and inflated. The benefits of the drugs were overinflated, but some of the real data came out in 2010, which showed that out of 4,000 people, about 1,500 got better at some point by their definition in this paper, which was actually a secondary definition of remission. But only just over 100 people got better, stayed well, and stayed in the study. And actually by the definition that they had specified in the protocol, even fewer people remitted. That's the orange column in this graph. And that data has only just come to light because the authors didn't want to publish it. So how is this the case when we have so many placebo-controlled trials that show what a fantastic thing antidepressants are? This large meta-analysis conducted in 2018 was greeted by newspaper headlines that antidepressants work after all. Now we have the evidence. Well, what this meta-analysis shows, as all other meta-analyses show, is that the difference between antidepressants and placebo after short-term treatment of around 8 weeks for most studies is very small. It's around 2 points on the Hamilton rating scale. The Hamilton rating scale, typically people are scoring in the late 20s or around 30 points when they enter a trial, and the total score is 52 points. And by any measure of clinical significance, that difference of 2 points doesn't cut it. if you compare it with the Clinical Global Impression Scale, this is an observer, a scale rated by a researcher or observer. If you use this, you find that if you have a Hamilton scale difference of 3 points, or change of 3 points, it doesn't register as a difference at all. And in fact, you need an 8-point difference on the Hamilton scale to register as showing minimal improvement. So the differences are small, but actually even these small differences may not be real differences, because many people in randomized controlled trials of antidepressants can guess whether they're taking the active drug or the placebo. It's not often looked at, the extent to which a study is unblinded, but where it is, antidepressant studies have shown that people can guess in many studies, not all. And this study shows the results of an antidepressant trial where people couldn't tell the difference between the drugs and the placebo. And what you'll see from these graphs is that according to the drug that people were allocated to, there was very little difference in the amount of change between the active drugs, in this case sertraline and hypericum, that's St. John's wort, and placebo. But people in this study were asked to guess, and if you looked at their outcome ratings in terms of what they guessed they were on, you can see there's a big difference. People who guessed they were on one of the active drugs improved considerably more than people who guessed they were on the placebo. So that is probably accounting for that small difference that you see in placebo-controlled trials, at least to some extent. These trials also support that point. These trials showed that people who had prior exposure to antidepressants showed a difference between the drug and placebo, possibly because people could recognize the experience of being on the drug because of their prior exposure, but also actually possibly because some of these people may have been taking the drug up until the point of randomization or just before randomization, were then randomized to placebo and then might have been experiencing withdrawal symptoms. I actually think that withdrawal symptoms may explain some of the poor performance of placebo or the slightly worse performance of placebo in some acute studies, because acute studies don't enroll exclusively people who are not taking medication before. They are often enrolling some people who are already taking it.
Joanna, please excuse me interrupting. We're getting some feedback that people are having trouble seeing your slides. Is there a way in which you can make them bigger on the screen?
Okay. There we are. Is that better?
We need some feedback from our audience. Can people see those slides better now? Yeah, I think we're getting some thumbs up and some much better.
Okay, that's great. All right.
Thank you.
Yes, and as you can see, among people who didn't have prior exposure to antidepressants, there was very little difference. Now, not only are the benefits of antidepressants minimal, but the vast majority of people have been misled about the nature of psychiatric drugs and their effects, including the effects of antidepressants. So these survey results that you can see here show that 85 to 87% of people, when asked, consider that depression is likely to be caused by a chemical imbalance. And this is an example of what I've called the disease-centered model of drug action. Apologies to people who've seen me talk about this before. This is the idea that drugs correct an underlying abnormality of the brain and their therapeutic effects arise from that. And as I've argued elsewhere extensively, there's no evidence to support this view that there are underlying abnormalities and that drugs are working by correcting them. And indeed, there is an alternative view that, to my mind, is much more plausible, and that's what I've called the drug-centered view. And this is the idea that the drugs that we prescribe for psychiatric problems create an abnormal or altered brain state. And the useful consequences that sometimes occur in some situations are a consequence of the drug-induced changes to normal brain functioning being superimposed on underlying symptoms, that is, unwanted thoughts, feelings, and behaviors. So this drug-centered model highlights the fact that psychiatric drugs are psychoactive substances, that is, substances that change the normal state of the body and importantly of the brain. That's what makes them psychoactive. Because they work on the brain, because they change the normal state of the brain, they produce changes in normal mental activity, that is sensations, thoughts and emotions, and in behavior. And all drugs affect the body as well as the brain, so there are also linked alterations in other physical symptoms, in other physical systems. So, for example, drug-induced sedation has mental and physical components. And psychoactive drugs can produce feelings that are pleasant, and then and those, for some people, and those drugs by definition can become recreational drugs. But some of them produce feelings that are generally experienced as unpleasant. It doesn't make them any less psychoactive. They're still changing the normal state of the brain. And examples of those sorts of drugs are drugs like antipsychotics that most people find fairly unpleasant to take, whether or not they decide there may be some benefits to taking them. And as I said, there's no evidence that the disease-centered model of drug action is correct. In particular, there's no evidence that any mental disorder that you care to name is caused by a deficiency or abnormality of a brain chemical that might be, or any other process that might be reversed by a drug. There's some references for that. And this is just a table to summarize the psychoactive effects of different sorts of psychiatric drugs, just to emphasize the sorts of changes that they produce. So antipsychotics, for example, are highly sedating, most of them anyway, and cause mental slowness and subjective and objective cognitive impairment, emotional blunting, loss of libido and motivation, initiative, etc. And it's important to understand as well that there are other ways of understanding mental health problems. We don't have to think of them as diseases. We've been coached into thinking of them in this way over the last few decades, but this is not the only way that we can think of them. And this report by the British Psychological Society emphasised that depression can be thought of differently, is best thought of as an experience or set of experiences rather than a disease. And like other emotions, is often an understandable human response to the world around us that involves complex evaluations of events. And emotions necessarily involve us evaluating our circumstances. So what are the implications of the drug-centered model? Well, first of all, as I've said, that drugs modify the normal state of the brain and the body. And by doing this, they modify normal as well as abnormal thoughts, feelings, and behaviors, i.e. symptoms. And we should assume that changes to the normal state of the body and brain are harmful unless we can prove otherwise, especially if someone is using a drug on a daily, continuous basis. And there's lots of evidence that taking these different drugs is harmful, particularly the fact that some of them have some very protracted adverse effects, some of which persist after the drug has stopped. And most people, of course, haven't been informed about this because they've been presented with the disease-centered model, with the idea that the drugs are working by rectifying an underlying abnormality, either explicitly or implicitly. So just want to say a couple of words about what David Healy has called legacy effects. These are effects that persist when the drug is stopped. So one of the first legacy effects that was identified was tardive dyskinesia. This is this state that occurs with long-term use of antipsychotics. it is defined as involving involuntary movements. But what is often not emphasized is that actually the involuntary movements are associated with some degree of cognitive deterioration, intellectual decline, which emerges over the same period as the abnormal movements emerge. And although it's probably less common than it used to be, because we thankfully use lower doses of antipsychotics than we were doing in the 1980s anyway, it still is fairly frequent, especially among older people who seem to be more susceptible. Another legacy effect, of course, is the prolonged withdrawal effects following cessation of drugs that I know that you've been discussing yesterday. And these seem to particularly occur after the withdrawal from antidepressants and benzodiazepines. As I mentioned earlier, these were identified by Heather Ashton in the late 1980s and early 90s, when she wrote up cases of people who'd stopped benzodiazepines but still reported persistent symptoms, including anxiety, depression, insomnia, but also some physical symptoms, including tinnitus and restless legs. And there's been an excellent paper recently published in Therapeutic Advances in Psychopharmacology, which describes all the symptoms that can occur following benzodiazepine withdrawal. So as you can see, there's a whole great range of these, with many of these symptoms persisting in many people for months and for years. The other reason this paper is very interesting is it highlights how debilitating these symptoms can be and how much they can interfere with people's, create an enormous problem for people's work life, recreational life, social life, relationships, etc. As you can see, almost half of the population of people reporting these problems were reporting that they'd had a significant impact on these various areas of their lives. And people reported specific effects as well, quite commonly, significantly, you know, over 50% reported that these effects had significantly affected their marriage or other relationships, that had led them to have suicidal thoughts or attempt suicide, had led them to lose a job, and other consequences. And as I'm sure you heard a lot yesterday, antidepressants produce a similar range of physical and mental withdrawal symptoms, which can be very prolonged and can persist after the drugs have been stopped completely. And these two studies seem to suggest that the duration for most people is around 1 to 2 years. But obviously with some people experiencing them for longer. In the study that we looked at, the database we looked at, 25% of people had persistent symptoms for 2 years or more after stopping SSRIs. The other legacy effect that is attracting increasing attention in the sexual health literature, but is not being discussed enough in the psychiatric literature, is persistent sexual dysfunction following cessation of SSRIs in particular. We know that SSRIs commonly cause sexual dysfunction when people are taking them, and there are increasing numbers of people reporting to sexual health clinics and other doctors that they are having persistent problems, particularly genital anesthesia, pleasureless or weak orgasm, decreased sex drive, erectile dysfunction, and premature ejaculation. So all that was really to come to this conclusion that there are good reasons to try and get off psychiatric drugs. First of all, they are not normalizing or helping any underlying biological abnormality. Secondly, beneficial effects have not been established for many of these drugs in many of the indications they're commonly used for. And thirdly, long-term use is affected with many harmful effects and poor outcomes, and also with these legacy effects after people have stopped the drugs. So just moving on to withdrawal now. I think I'll skip over that because I've talked about that. So there are various adverse outcomes that can happen after someone has, when someone starts to withdraw from a drug or after they've stopped it. They can have a physiological withdrawal reaction. They can possibly, in theory, there might be some underlying damage which is triggered or unmasked by stopping the drug. People can have a psychological reaction. They can become very frightened about reducing the drug, and that might be compounded if they're experiencing withdrawal symptoms at the same time. People may experience a relapse of their underlying condition, and that may be precipitated by the process of withdrawal, or they may have a relapse that is due to the removal of the beneficial effect of withdrawal, or they may just have a coincidental relapse or deterioration. Number 5 is the one that has always been presented as the explanation for adverse effects after withdrawal, that you've had a relapse and that just shows that you needed the drug treatment, that's what was keeping you well. But there are all these other possible explanations for what might be going on if someone has a bad reaction during or after stopping a psychiatric drug. Psychological reactions. In my clinical practice, I do think that these are quite significant because people can become very frightened about the process of withdrawal. And this is partly because they've been told for years that they need these drugs, that they have a defective brain, and that they need the drugs to put the brain abnormality right, to correct their chemical imbalance. There are a couple of studies showing that people who believe that their depression is due to a chemical imbalance are more likely to want to remain on long-term medication and less likely to want to try and come off it. And of course, this anxiety and fear about stopping may be misdiagnosed as a relapse. And it doesn't just affect the person, the individual who's coming off the medication as well. I often experience the situation where people's relatives and staff are all very anxious and fearful about someone withdrawing from medication, and that of course can impact on the individual. So what about withdrawal effects? They seem to be more problematic with some drugs than others, but drugs that act on the central nervous system appear to be especially prone to induce significant withdrawal effects of some degree. They do occur, however, with some other drugs. Some antihypertensives and steroids have been associated with withdrawal effects. They may reflect the opposite of the acute drug-induced alterations, such as insomnia and anxiety with benzodiazepines, but they're certainly not exclusively limited to those. And overall, I would say that really they're just very unpredictable and not well researched. So what about withdrawal from antipsychotics? Well, there's a physiological withdrawal reaction, which varies a bit depending on the type of drug that's been induced, but broadly involves agitation, insomnia, which you would expect given these drugs are very sedating, and GI symptoms because they affect the gastrointestinal tract. There's also evidence that some people can experience a psychotic reaction, which is part of the withdrawal state. Sometimes this is referred to as supersensitivity psychosis. There's also the suggestion that the withdrawal from antipsychotics can precipitate a relapse of an underlying psychotic condition. And then, of course, there's the possibility that there might be a relapse caused by withdrawal of beneficial preventive effects, or possibly suppressant effects on someone who has underlying chronic ongoing symptoms. And then again, there are the possibility of psychological reactions. So what about supersensitivity psychosis? I prefer to call it withdrawal psychosis because I don't think that we are clear about the mechanism. Guy Chouinard, a Canadian psychiatrist, coined this term supersensitivity psychosis in the 1980s. And he suggested that this is when symptoms of psychosis appear either when antipsychotics are reduced or discontinued, or sometimes it can be new and more severe symptoms can appear while people are still taking the medication. he suggested that a sudden decrease is more likely to induce symptoms than a gradual decrease. And he proposed that the mechanism was supersensitivity of the dopamine receptors in the limbic system, and proposed that there was an analogy to the mechanism for tardive dyskinesia. The problems with the literature are that it's very difficult to distinguish chronic symptoms from re-emerging or worsening symptoms, particularly because psychosis is always a fluctuating state. Symptoms can get better or worse. And the suggested associations with tardive dyskinesia and prolactin have been inconsistent. And basically the mechanism, and as I said, particularly the idea that there's a causal role for supersensitivity of the dopamine system, have not been proven. However, there are some definite documented cases of withdrawal psychosis which have occurred in people who've been on antipsychotics for purposes other than people who don't have a history of psychosis. Either they're on them for physical purposes as anti-nausea treatments often, or they have non-psychotic mental health problems. There's also it's also common to come across a withdrawal psychosis in people who are taking clozapine. This is one of the reasons why I think that dopamine is probably not likely to be the only thing involved, because clozapine has a relatively weak action on the dopamine system. So there have been numerous case series showing this clozapine withdrawal psychosis, and one randomized controlled trial. It seems to come on very abruptly, more abruptly than probably with other antipsychotics. And the typical symptoms are paranoid delusions, which obviously are frequent in other sorts of psychosis, and auditory hallucinations, but also people often become uncharacteristically hostile and aggressive, and sometimes they get visual hallucinations as well, which are not so typical of other cases of psychosis. And the prevalence in this randomized controlled trial was 25%, but it's higher in some case series. And I think the most convincing thing about this data as well is that there are a couple of studies showing that the symptoms that people get after they stop clozapine are worse and more severe than they were prior to starting on the clozapine, suggesting there's something about the withdrawal process going on. The ability of antipsychotic withdrawal to produce either withdrawal psychosis or relapse seems to be less with, it is higher, the risk is higher in the months after cessation or withdrawal, and it seems to be lower with a gradual discontinuation rather than an abrupt one, as shown in this graph. And this is, of course, is why I'm doing the radar study, just getting a quick shout for that, which is this study where we're looking at the outcomes of doing a gradual and supported reduction of antipsychotic medication. I'll skip over that because I'll just get to my last slide so that we've got time for some discussion. So I just wanted to say a couple of words about lithium discontinuation. The research shows that there are very high rates of relapse following lithium discontinuation in people who have a diagnosis of bipolar disorder, and it's particularly mania that people experience. And the risk is concentrated in the 12 months after discontinuation, but higher, in fact, in the 3 months. And again, the most persuasive evidence that it's something about discontinuation that is precipitating a relapse is that the rate of relapse prior to after lithium discontinuation is higher than it is before lithium was started. That's been shown in 3 separate studies. Again, the risk seems to be a bit less with gradual versus sudden discontinuation. And there are 1 or 2 studies showing that there may be a risk of people who are taking lithium for other indications having a manic episode when they stop lithium. The mechanism is unknown, but it does seem to be related to the ability of lithium to basically, radically suppress nervous system activity, so that when it's stopped, you've got a huge sort of rebound activity going on. So in conclusion, we need to be a lot more cautious about starting treatment, especially long-term treatment, and we need a lot more research on withdrawal-related problems and particularly in prolonged problems and legacy effects. Okay, so I hope I've left some time for discussion, Stevie.
Thank you very much, Joanna. Quite a few questions have been posted, and I'd just like to very briefly answer one or two of them. Again, people asking where they can get information. Where can I get information from my friends, family, medical team, particularly if they don't believe me, and that sort of thing. And on the IIPDW website, iipdw.org, we now have a research and information tab where we are putting all the latest research on the subject of psychiatric drugs, the very latest that you can find, so that you can print that and take it to your family, your medical team, whatever. Yesterday we told you about sources of information via Laura Delano, the Inner Compass Initiative and the Withdrawal Project. Very good places to go for information. And Joanna has a book called A Straight Talking Introduction to Psychiatric Drugs, The Truth About How They Work and How to Come Off Them. This will be an excellent resource for information too. So asking Joanna now directly, one of the questions is, Dr. Moncrief, what can you tell us about the long-term effects of antipsychotic drugs in developing brains, i.e. for people who started to take them when minors?
Yeah, good question. So it looks as if their effects are more serious and more damaging in young people. Young people are more likely to get tardive dyskinesia than adults, and they're more likely to get diabetes and endocrine metabolic problems than adults as well. So I don't think there've been any studies on brain volume in young people, children or young people, but certainly, yeah, there's evidence that the developing brain is more susceptible than an adult brain.
Question about the Critical Psychiatry Network, Joanna. Someone is asking, how can they find a psychiatrist sympathetic to the views of the Critical Psychiatry Network, specifically Bristol and Geneva, but I guess that can be a question worldwide. Where can people find information?
So I think you've covered where people can find information, but finding a sympathetic psychiatrist is not that easy, because, as everyone's probably aware, in the UK, your psychiatric services are local, and you will be allocated to your local psychiatrist, and it's not that easy to go to someone who's not working in your local area. You can in theory ask your GP to refer you to another psychiatrist in another area, and then you would have to apply, or your GP would have to apply to the general practice funding body, the clinical commissioning group, to get funding for you to go and see someone in a different area, and that can be done, although it's a bit cumbersome and bureaucratic. What I would suggest people do is first of all, go and, if you're not happy with the psychiatrist you're seeing, make sure that you've been in with your questions and concerns clearly written down on paper so that they can see them as well. Take someone in with you always to support you. If you're not happy, if you still feel you're not getting good results, then ask for a second opinion and ask around, ask other patients in the local service who might be sympathetic in your area. Often there will be one or two people who are going to be more supportive for you if you're someone who wants to try and get off your medication. And if that doesn't work, as I say, there is this option of going to someone in a different area if you can persuade your GP funder to fund you.
Thank you. There's questions that come up around delayed withdrawal, Joanna, which I think came up yesterday as well. We know with antidepressants that there can be a delay depending on the long or short half-life of the drug. Is there a delay in coming off some other psychiatric drugs? One person is asking here particularly about, and excuse me if I pronounce this long, clomipramine and other psychiatric drugs. Delay in withdrawal manifesting itself, I guess, is the question.
I can only say that there's very little data about it. People in this webinar probably know as much about it as I do or anyone else does. You know, we're getting reports on withdrawal websites that this occurs, that you know, that there can be this delayed effect. I haven't heard of it happening with clomipramine. I've heard of it happening with benzodiazepines and with various antidepressants, SSRIs and venlafaxine. I've heard it occur with. So, but I wouldn't necessarily rule it out for other sorts of drugs. I think it's just difficult to say. We just don't have enough data on it.
Thank you. And lastly, I think, do you have any suggestions as a psychiatrist yourself how to discuss this sort of information with treatment teams that try to say that the patient, you as the patient, lacks insight if you want to come off psychiatric drugs?
So I think psychiatric staff need a lot of education on this issue, and you know, all of the professionals here, I'm sure, try and do that in their own local service, but it does need to happen. It needs to happen nationally through professional bodies. This message needs to get out. This message about withdrawal symptoms, about, you know, the possibility of mistaking relapse for withdrawal. So the right way around, withdrawal for relapse. So yeah, we need a lot more education. You know, lots of health professionals are trying it in their local areas, but it needs to be rolled out more widely, because it is, I think it is very difficult, and it's really difficult for patients if all the staff are, you know, are against you and telling you, no, it's not real, you just need to go back on your medication.
Yeah, it's almost a case of having to dig your heels in, I suppose, that those of us who are making change are having to shout as a louder voice above all the people that are saying that, no, it's you, not the drug. And that's a very, very difficult banner to carry. It's you, it's not the drug. And we have to just keep saying, no, it's the drug. Yeah, it's the drug, it's not us.
Yeah.
So thank you very much. We are going to take a break now for 30 minutes. So we are coming back at 4:15. And one of my colleagues from the board, Cleo, I think, is going to be introducing Magnus Hald to tell us about drug-free treatment in Norway. And I have seen in some of the questions, people saying, well, this is all very well talking about drugs, but what alternatives are there to drug treatment? And we are going to hear that from Magnus. Thank you very much.
Hi, Cleo. Can you hear me?
I can hear you.
Okay, very good. Then we're so far. Problems getting on here. I don't know what it was, but now I
Hello,
seem
Magnus.
Hi, good to see you, Lucy. You're doing a great job. Thank you so much.
So far it's going okay.
Yeah, and that's what worries me, you know. So far, I mean.
Yeah. We have a
So,
bit
yeah.
more time in the break.
Yeah.
So at 1:15, we will start your talk.
Yeah, that's what I understand.
Okay, great.
Yeah, so I'm not quite sure.
You
Hello?
can just
You can see me?
Yes, I can see you and I can hear you. You can turn your camera off and your microphone off so that you can have a break until.
But do you? I would just try to see if I manage to share screen.
Okay.
Good idea.
And I'm not sure if that's if I'm when I open the screen here, it seems to be difficult to see. Maybe I can. No, I probably.
There is a button at the bottom. It should be called
Yeah,
share
I see
screen.
that, but the problem is if I try to have the presentation mode, then I lose the whole screen. So if I first then maybe share screen. Yeah, then I just see you because you're on the screen. So if I put up this, and how is it possible to have this open and then at the same time share screen?
Maybe with the view button.
Yeah, maybe that's the possible, because when I turn on the view button, then it covers the whole screen. Then I can't see the share screen button on the bottom. So that's my problem. So how do I do that?
So you see only the share screen and just yourself or someone else?
No, I see you also. Maybe if I use the window here, yeah, there I can go in on the window and then I can put share. Do I now share the screen?
Yes.
Yes, we can see it.
It's working now?
Yes.
Yes, it is.
Okay.
And if you have a presentation mode, shall we test that to make your slides look bigger?
Yeah, I tried to put it in the presentation mode now, but
Let's
maybe
see.
that didn't work. I will put it back in. Now I'll put it in. I will try to do it again.
Then do it after.
Share screen and then window and then share. Participants can now see your screen, okay? And then if I try to have it in a show mode now, it's in the show mode. Do you see it?
Looks the same.
No, so it doesn't work that way. I think maybe, yeah. So
With
that's
the
my
zoom?
problem.
Zoom in or out?
Yeah. If I zoom, then that doesn't work. It just.
So I would close the left column.
Yeah. I will try. There was a different option too on when I tried to share screen. There was also this option, Chrome, it's a window.
Perhaps you can make the left column smaller by dragging it on the edge. Click on the edge and yes, drag.
Because I can, but the problem is I should be able to have a show. It is possible, you know, to share the presentation mode of the screen. That should be possible. So it's something that I don't understand that makes that impossible, but maybe it's just.
That is the way Joanna did it. So she must have had the same trouble. I'll Google it on my phone, but I can't promise to find the answer.
That's the best we had so far.
Yeah, but we will see if there are.
It says on Zoom's website that you should be able to press play and put the play mode. Once you've shared the screen, go back into PowerPoint and press slide.
Press play.
And play.
Yeah, that's what.
But it's not working, is it?
No, that was what I had problems with, but I can try that again, of course. And then I will share screen. Oh no, I lose everything. I don't know. It's like I said, you know, it worked fine so far. Share screen. Yeah, I will.
We have a suggestion from the audience. Maybe if you put your presentation into first, you put the presentation on presentation mode, and then you share your screen. Maybe.
Yeah, that's what I've done. I put my presentation on, but if I put my presentation on and then
share screen, doesn't work.
No, that was the problem.
Because you couldn't. Okay. Could you press the escape button on your keypad to make it go?
Yeah, maybe that's possible.
Yes, Zoom is saying you need to do it that way around.
Yeah. There's something happening now that I really don't understand, so I have to. Maybe I should try a different computer here. Still have 15 minutes, yeah. I'll try to log on from a different computer and see if it works better.
If you want to, at least we could see your slides.
Yeah. Okay. Then if it doesn't work with the other computer, I will. It's a network problem with the other one, of course. Does it work now? Lucy, can you hear me?
Do you have it on presentation mode?
I have it on presentation mode now.
Can you zoom in?
Not when it's in that mode, but it's.
Yeah. It was better in the other mode and just zoom in.
Yeah.
But it was in presentation mode now, wasn't it?
No, we never saw the presentation mode here.
Okay, so you don't
Yeah.
get it in press. Yeah.
So maybe this is why Joanna had it zoomed in.
Oh, it doesn't work.
I think leave it and just do it the normal way.
Okay.
Looks good.
Is it better
I think
now?
that's the best.
Yeah.
I think yes.
But if you take it out of presentation mode, I think it will look better.
It's not in presentation mode now. Now it's
Okay.
it's so now it's in. If I can try presentation mode, and you can see what it looks like.
A couple of minutes ago, it was bigger.
Now it's presentation mode.
Oh, it looks the same.
It looks the same.
Yeah.
Yes, it
Yeah.
never changed to presentation mode for us. But, if you can send it to me, and then I can try.
I could share it.
Okay, Lucy, could you share it?
If Magnus just tells me when to move from slide to slide.
Yeah.
Yeah, well, I think that's difficult, but I can try to do that. But why doesn't presentation mode work? Because I put it in presentation mode, and you say it's not working like that.
Somebody in the audience says maybe you're sharing your PowerPoint rather than sharing your screen.
Yeah.
Or maybe sharing your screen rather than your PowerPoint.
But yeah, I think that's.
If you press shared screen at the bottom,
yeah, that's what I've done. I press shared screen at the bottom, and then I go to window.
It gives you options. So you could, there's a tab called advanced. You could have a look at the advanced options. I can't see if they would help anymore.
You see me now?
Yes.
Very good. Yeah, when I go to, you said when I go to shared screen at the bottom.
There's different options, and there's also a tab called advanced. But I've looked at it and it doesn't.
I have just 3 tabs. One says the whole screen, one says window, one says Chrome.
Okay.
Yeah.
But if you look at the top of the, Actually, don't worry. I'll probably say unhelpful things.
No, I'm not
Maybe
sure about that.
complicated. There is a tab at the top, so you can see basic, advanced, and files. Have you got that?
Yeah, basic, advanced. No, I have not got that. I have got the when I go to share screen. That's when you say I see that.
Yeah,
But
just at the top
what
of
I
that
see the whole. It says that 3. It says the whole screen, window, and Chrome. Chrome.
Mm.
That's what it says.
But above all of those things, have you got a tab saying advanced?
No, I have not. Do not have a tab at all above that. There are no
Okay.
tabs. I'm sorry.
Okay.
Sorry about that, but that's how it is. So
Okay.
yeah,
Well, if it
but
isn't that hard, Magnus, if you can, if you think that you can tell Lucy when to change, so maybe she could share. If you don't think so, then the last time we had a zoomed in presentation, maybe enlarged slide was the best option.
yeah.
Whatever makes you comfortable.
I will see if it's about how long. You don't see the slides now at all, do you?
No.
No, that's how big it's possible to make them.
That's good. That's much bigger.
Is that bigger?
Yeah.
I hope I'm not really I hope I get most of the time we'll get the whole slide in, but it's yeah. I'll just have to do it like that.
I think that works.
Okay.
That's the best we got.
Do you want to
Yeah.
It's
go
fine.
to the bottom?
I'm sorry.
No, I think it's good. I was going to say if you want
Okay.
to flick through them and we can see, check they all fit.
Yeah. I can try, but now it's 5 minutes. I can also regulate them somewhat, I think.
Yes, each one you can make a bit smaller at the time.
Yeah. Still good enough?
Yeah, really good.
Okay.
Really good.
But I really can't understand why this doesn't work, because I have done this before and it's worked.
I'm wondering
I
if
have
the where you are needs to update their Zoom. Maybe it could be an idea.
Maybe there has something to do with because I'm at the hospital, and it has something to do with the hospital firewall. I don't know.
Well, it's good now. So thank you for joining early and thinking ahead.
Yeah, I hope it's we'll hope it will work. Yeah. Yeah, it was just 4 minutes. I'll get a glass of water.
Yes.
Okay.
Me too.
So, first of all, I would like to say that I see from the questions that many ask about the slides from the keynote speakers. As soon as we have their answer on that, they may be distributed via email to all of you, but we cannot say for now. And just to remind that after the conference on Monday, you will have an email for viewing the recorded sessions for 2 weeks, for 2 weeks time. Okay, you will receive an email with a link that you can have access for 2 weeks to the sessions. So, Magnus, I'm very happy to be here and introduce Magnus Hall. He is a psychiatrist, and for over a decade, he's the director of the Division of Mental Health and Substance Abuse, University Hospital of North Norway. He's been long interested in the development of a network-oriented perspective on mental health, based on ideas that have come from his work with reflecting teams and reflective processes. And he's behind the Med-Free clinic that started in January 2017 in Norway, and we are all very, very interested in hearing about this wonderful alternative to medication, to treatment without medication. Magnus, welcome. And unmute yourself.
It up.
That's great.
Okay.
Yes, we can hear.
Yeah. Thank you for inviting me, and thank you for the nice introduction. Now you can hear me also, and I hope that it's possible to see some of these slides, although we had some problems. It doesn't work in show mode, so we have to use a different mode, and I hope that's still it's possible for people to see. And I would also like to, I just must say that I find it, it's different to speak to a camera than to speak to some people where you can have eye contact. Eye contact over this medium here is just an illusion, and but I hope it will be in some way meaningful. I will talk some then about the drug-free treatment in Norway, or maybe rather the drug-free treatment in North Norway, because that's what I know the most about, and I might also say something about what's happening in the rest of the country. And I think I'm amazed that so many people use their Saturday night for this, and I hope it will seem worthwhile. Anyway, northern Norway. First, I would say that drug-free treatment in our facility is basically a possibility for persons with serious mental problems to choose treatment that does not include antipsychotics or better neuroleptics, which better describes how this group of medication works. I must also then, excuse my failing, my limited command of the English language, but you must bear over with that since you invited a Norwegian, and I will talk, I think, about this. First, a little about the context, because I think the Norwegian context is very important for what it has been possible to do here, and a little about why that context in one way produced medication-free treatment as an option, a little about the mandate that we got when we started to establish this, and how we decided to organize, and how the program has been, and a little about what we have achieved maybe. So first about the context. Northern Norway is far north. You can see the map here with the Norway, kind of the coastal line of the northern part of Europe. We border both Sweden, Finland, and Russia. And there's always been a close connection between the people in this region. Tromsø is located right there, and that's where I'm sitting now. And Well, the cooperation that we've had with the other countries also in the field of mental health made us re-establish a lot of the contact that we used to have with Russia from in this part of the country from around 1700 until the revolution in 1917. And there was a special strong connection between the Archangels region that you can see on the White Sea and the northern part of Norway. It was actually so close that they developed a common pidgin language where they could be able to, that they were able to use for trading and for sharing things. So that was a very historically a very important connection, and it was re-established during the period of perestroika and glasnost. And so I traveled to Archangels together with Jaakko Saikula and Tom Anderson for, I think it was 3 or 4 years. We traveled a lot and had, some kind of training program going on there. And the Russians, they called what we were doing for democratic psychiatry. That was the Russian idea about network-oriented practices. And I actually, when I've been thinking about that lately, I actually think that democracy is an important part of the context for the Norwegian context. And democracy in Norway, and I think in many parts of the world these days, it's important to talk about democracy because democracy is kind of threatened in many parts of the world. And I also think that democracy in Norway has some special features. It's characterized by, the differences between people, the differences between people that are rich and the people that are poor. They're not as big as in other countries. And we have a system with to a very large degree, equal opportunities for people when it comes to education, jobs, and equal access to healthcare. And in Norway, the healthcare system is basically a public system, and it's this also then goes for mental health, and it's organized in this way: primary healthcare is the local and town responsibility, and specialized healthcare is state responsibility, and it's organized what you might in a way on different levels. So. It's organized, the specialized healthcare is organized in 4 regional health trusts. And here you can see the 4 trusts. It's one in northern Norway and 3 in the southern part of Norway. And the northern part, the Northern Norwegian Health Trust, is where we are located. And it's a very large geographical area, but it's a small part of the population. It's some 10% of the Norwegian population, and the Norwegian population altogether is a little more than 5 million. So it's, just around 500,000 people in this area. And the university hospital is a university hospital for this whole region, and has a psychiatric hospital for parts of this area and the psychiatric centers for even smaller part. There have been 2 central messages, so to speak, for the healthcare system in Norway for quite a few years. And the one idea which is very strong with the government is that we should now have the patient's healthcare system. And that means that the interest, the experienced interest of the patients and the patients' organizations should be decisive for how we organize and and also in clinical work. Like the late Health Secretary Bent Høie said this in 2015. The basic question is, if the patients were given the right to decide, how would we organize and run the healthcare system? This is a radical question. The answer we get should be taken seriously, and it should be decisive for the work with the patient's healthcare system. So that's been that's one of the bearings, so to speak, for how we organize. And the other is what's called the golden rule, which of course is the law of reciprocity in many religions. You should treat others as you want to be treated yourself. But in Norway, that's not what we what people will think about if you ask people in healthcare what is the golden rule. They will say it's the it is that treatment programs in mental health and substance abuse shall be have a higher yearly growth than programs in somatic medicine. And this goes to all these measures, numbers of employees, waiting time until consultation or treatment, number of outpatient consultation, and economic growth. So that's been a goal for almost 15 years now within healthcare in Norway. And although it's a goal, we have never really achieved it, and there are different mechanisms that's debated a lot all the time that makes it difficult to really achieve this goal. But at the same time, it has resulted, I think, in more resources to mental health care than in many other places. So why medication-free treatment? And then I must say that, the medication-free treatment is not in Norway an idea that came up within the medical or psychiatric community itself. Not at all. This is solely a user or this is organization. This is something that users and organizations have demanded for a long time. And it's been very difficult to get through with the idea of medication-free treatment. And the government for a period of time would say, well, there are so many different opinions. We really don't know who to listen to. So, the professions, they don't think this is a good idea. So it took a long time. But then in 2010, different service user organizations, they united, and it was actually not possible not to listen to them anymore. So these different organizations joined. Almost all the Norwegian user organizations or advocacy groups joined, or except the ADH group, which sometimes some people say that they want more drugs and not less drugs, but the other organizations, they joined. And the health secretary had to, tackle this demand from the user organizations. And what he did was he told the regional health trusts that they should establish this in one way. And the way things is being told in Norway is this way. There's a regulatory document that is actually sent through the system from the government and all the way out to the providers. And what happened? Well, actually, this order was given from about 2010. And what happened? Actually, in 2010, nothing happened. 2011, nothing happened. 2012, nothing happened. So nothing happened. Although this is what was stated in this document almost every year, that patients in need of psychiatric help shall, within prudent frames of treatment, have the choice of different treatment options. Amongst these, treatment options that do not include the use of medication. These options shall be developed in close collaboration with the user organization. So I think then the health secretary got kind of fed up. So in 2015, when nothing had happened, there was sent a special letter to all the regional health trusts. And in this letter, it said that each regional health trust shall establish alternatives to medication, including help to tapering and termination of use of medication, and help to establish other therapeutic treatment measures. And also for patients that are admitted to psychiatric treatment facilities and that are being treated with medication, there should be made plans for tapering, termination of the treatment with drugs. I mean, this goes for patients that are admitted to the whole psychiatric system in Norway, actually. And also to obtain experience with medication-free treatment of patients with serious mental problems, each regional health trust must establish at least one bed unit reserved for this purpose. So this was a kind of an order, and it was very strict, and it said you have to do this within half a year, or we'll come after you. That's basically what the government said. So it became impossible for the different health regions not to do anything about this anymore. And the health minister, he demanded that this was done in a specific way, that the different regional health trusts had a discussion with the affected user organizations, and that they had to come up with a unified proposal for how this should be done. And when both parties signed this proposal, then they had done what they were supposed to do. So he made a, he said that you have to have an agreement with the user organizations. Each health trust have to make a plan with the local user organizations about how you can come about with this command that you've gotten from the government. So this is how it came, and yeah. So these were the three or the main things in this order that was given from the government. And I think there were special things with it. It's both the drug-free thing, and it's also a new thing for us in Norway, at least, that user knowledge should be included on an equal basis in the planning process. For a long time, users or people with patient experience and things like that have been included in planning processes. But this, I think, was the first time when these organizations were included on an equal level. So we should have this regional plan, and we should make a local plan. And so we kind of got at the hospital here, we got the regional protocol, and from that protocol we were supposed to make a drug-free bed unit, because the protocol said that there should be established. We should give priority to establishing 6 beds, and it should be done at University Hospital in Tromsø. The reason we got it was because no one else wanted it, and we said we wanted it. So there was not a big competition. But at the same time, it was said that the drug-free program should have a regional responsibility. So that was an important part of it, the regional responsibility. And that, of course, 6 beds and the regional responsibility was is very challenging, which I will come back to. And it said in the protocol that the drug-free treatment should secure choice options for patients, is a part of a major effort to reduce the use of psychotropic drugs, is based on patients' choice, should focus on cooperation with local treatment programs, should include recovery perspective, should be network-oriented, should engage families of patients, focus on activity, job, school, network, help patients be independent, employ people with own experiences. Patients and employees must together develop a program that they can believe in. So we have been told that we have to believe in what we're doing, and we have to follow also national treatment guidelines. That's been challenging because the treatment guidelines are often full of drugs. The Norwegian treatment guidelines are very closely linked to the NHS guidelines in England. I think they often translate parts of it, or at least they use it as a very big inspiration for creating local guidelines. It says also that it shall be based on the main ideas from the user initiative, and that was that patients shall not be subject to coercion or pressure to use any kind of medication. And I think that's one of the reasons why the user organizations thought that we needed specific places for this, that we can't say that, this is an offer that should be given within the ordinary units that we already have, because there's so much medication there that it's very difficult, I think, to really differentiate between different patients in a way that makes patient not experience some kind of pressure to use drugs. And the most important aspect of the treatment is to provide a safe environment, a bed to sleep in, someone to talk with, and regular meals. And I think that's very good, although colleagues of mine have said, well, this cannot be specialized mental health services. I think it's a very good idea, and one should also emphasize on the development of good treatment culture for drug-free treatment that can contribute to the development of new needed knowledge. And drugs shall not be an important part of the treatment that is offered, but shall not be refused to patients that want drugs. So it's kind of open in that respect. And these were the criteria they said we had to use when admitting patients. We have no coercion, only motivated patients, priority to patients with psychosis or bipolar disorders, referrals only from specialized services, no acute admissions, no patients with major problems with substance abuse, only safe therapeutic procedures, what that might be, and tapering of psychotropic drugs prior to admission. The last point there, we had to, to really, that was not possible. From the first day, we understood that, tapering is a major challenge for people that have been using drugs, and all people with serious mental problems in Norway, at least 99%, are exposed to drugs at some time. I think it's very difficult. So, and we saw that people that have been using drugs, they need help to taper. So from the very beginning, we said, this we can't follow. We have to be able to help people taper drugs. And we have noticed that the knowledge about tapering is very limited within the medical community in Norway. And we look at it as one of our major tasks is to kind of spread the knowledge about this. Although, the development of drug-free treatment programs have really focused on this in many ways. So in Norway, the Norwegian Psychiatric Association has made their own manual for tapering antipsychotics, but it's not very good, I would say. It's based on very limited experience and little knowledge. But I think it's a good idea that they've done it. I mean, they've tried. How to organize? We tried to find out if there were any similar things anywhere else, and we find that there were no other places that we could find that where they had tried to organize this kind of programs within the public mental health system. So we of course were aware of Soteria projects, different places, and we looked into some of them, and they seem to use more drugs than I would have expected from Soteria places. But I think new places have been developed since we started this project here back in 2017. And we, from the very beginning, it was very clear to us that we have a huge area, and we need to be able to offer treatment, although I don't think treatment is a good word, but I use treatment, but probably collaboration would be a better word. So we had to, be able to collaborate with patients from this whole region, and to be able to collaborate with more than 6, it would be a very good idea to try to make the programs together with local psychiatric services. So we have, from the very start, been very occupied with establishing what you might call the network-oriented program. And I think the network and web perspective and the recovery perspective is very central for the program. And generally, you're confronted with a treatment chain when you try to plan psychiatric services. At least in Norway, we try to use treatment web as an alternative to this. And we think that the web perspective makes these features more in the foreground, so to speak, while a kind of at least in Norway, I think when you treat people in a kind of a chain understanding, you will basically communicate with people in other parts of the system with written material. We try to always work in a very concrete network perspective. So we would say that the drug-free treatment unit should be a new possibility in the mental health treatment web, so to speak. And then also recovery, and these are recovery can be talked about in very many different ways. I won't talk very much about it now, but it's it's a well-developed way of thinking about mental health problems, and these are some of the headlines that I find meaningful. I think this goes actually back to the civil rights movement in the United States in the 60s and 70s. That's when today's recovery ideas started to be developed, but I don't have time to say more about that now. I'll say a little about the program, the concrete program, and we will then get written referrals from service system and the patient, she or himself, and we will then generally meet with everyone involved on live or Skype, and That will be, the patient, the private network, the professional network. So we'll generally start the treatment or the contact with us with such a meeting, and we will have meetings like this throughout the process. And patients will very often, after a meeting like this, come to the ward and stay there for maybe 1 to 3 weeks, and then stay at home for maybe 1 to 3 months, and then come back. That's a typical way of meeting with us, and where we are involved in the program all the time, and we will have network meetings, intermediate network meetings, either when the patient is in the ward or when the patient is at home. So we will say that our treatment or collaboration is both through these network meetings and through the development of the treatment network, and through what's happening when the patient is in the ward. So there's, in one way, 2 parts of this treatment program, so to speak. So the unit placed in the treatment bed is the one part, and the daily program in the unit is in one respect another part, where we have these different things that I can say. We have recovery workshops 4 times a week, where we have discussions amongst the patients that are in the ward and some of the personnel in the ward, where they share different experiences around different themes. We generally have one theme a week, and some of the themes are generally being repeated maybe once every half year, or sometimes even more. And then we have a physical exercise, a program with physical exercise, which is something that's for everyone 3 times a week, and then there are individual training programs, and we've had a lot of emphasis on physical exercise and training. There's art therapy, and now also some music therapy, both in group and individual. And then I see the time is running fast, so I'm going a little fast now, but
Don't worry.
we have had some experiences. I talked earlier about the rules for admitting patients, or the guidelines for admitting patients. We should have no coercion, and that in Norway you have to have no coercion. You have to have the capacity to give an informed consent, and the capacity to consent is sometimes difficult to evaluate. And what if the capacity to consent changes during stay in the ward, for instance, or during the program? How should that be? How should we look at that, and what can we do in such a situation? That's an ongoing debate. We should give priority to patients with psychosis or bipolar disorders. We have had quite a few patients that really don't identify with diagnosis that they've been offered by the mental health service system, and they prefer not to have diagnosis. And we don't pay too much attention to diagnosis, but generally will be engaged in the treatment programs for patients that have been exposed to neuroleptics, or that are in a situation where the system thinks that they should be exposed to neuroleptics. So we won't stick to diagnosis when it comes to who we offer in this program. And then referral only from specialized services. I think we're backing down a little on that, and thinking more about, we need someone to cooperate with generally, but the network is not just specialized services. The patient's network consists of very, very many different agencies and persons and families and things, and I think we don't stick too closely to that anymore. I don't think. No acute admissions. Some say that that's when it's most needed, and the patients that are in our program, some of them also come acute. So we say that, well, if you're so to speak, enrolled in our program, then you might also come when you're in a more acute situation. Only safe therapeutic procedures, well, that's also a question what that is, and we are not supposed to be an alternative, like alternative medicine thing, and we have to, in my experience, it's important for us to remain a part of the system, to be influential in the system. If we become too different from the rest of the system in this hospital, no one would listen to us at all. But as long as we are just appropriately different, we will be listened to. And so I think that's important for me to stay appropriately different. And as I said, tapering of psychotropic drugs prior to admission, that's not been possible at all. And we have used, at least especially in the beginning, we used a lot this harm reduction guide to coming off psychiatric drugs, which most of you will know, and also this guide from Volkmar Aderholt and Peter Stensley, when a guide to minimize minimal use of neuroleptics. So we have had good use of that, but we of course rely very heavily on the different people's own experiences, because most patients that we meet have experiences, of how they've tried to taper drugs, and many have bad experiences, and we try to discuss, how can we make it a better experience. So it seems to us that the patients on a very general level report two parallel processes. First, the gradual reduction of drugs, which is a challenge because we don't have the formulation of drugs often that is small enough for the last part of the tapering. We, for a period of time, used tapering strips that we imported from the Netherlands, but then the Norwegian Drug Administration said that they're not produced according to European rules, so you're not allowed to import them anymore. So we won't get them reimbursed, so we can't use those tapering strips anymore, which is very bad, I think, because we had very good experiences with using tapering strips, because that made tapering so much easier. It's more difficult for many patients to use a knife or to sit there and try to deal with the drugs, especially when you're supposed to have small doses. And also then the gradual increased access to feelings and thoughts, that's been to a much larger degree than I thought in the beginning. And positive experiences seem so far to outweigh negative experiences. And then what have we achieved? I think to put this on the agenda, and since we're a part of the system, I think we're in some ways more threatening to some people that are very medically oriented than we would have been if we had been outside of the system. So there's been a debate, for instance, already in 2017, there was in the Norwegian Journal of the Norwegian Medical Association, where central Norwegian psychiatrists went against us. Also, some of you have seen this article in the Journal of Psychopharmacology that some colleagues in a hospital in the southwestern part of Norway, they interviewed one another. They called it a qualitative research project, and they said that we're all against this because we're all responsible and we're all work evidence-based. So we have had this, and this is, for instance, this is the leader of the Norwegian Psychiatric Association. That would be like the president of the Royal College in Britain. I think redistribution of resources to medical free treatment offers that do not have a documented effect on those with psychosis makes the situation, that's the economic situation for mental health, even worse. Several places, important psychosocial treatment offers for those that need them the most are closed down to finance medication-free treatment offers to others. This, I think, is bullshit, and I have told him so. And then to finish up here, I think also these things is important, and we also have some patients, and actually we have some very strong advocates that have been taking part in our program, and that most of them have, and many that have been, in the newspapers, on television. And we have one that those that are interested can find in on the BBC web BBC page. Yeah, I will drop this, and I will then say that we hope to be able to present more solid data, so to speak, to present more. And we were late to establish this research project, but it's going on from this spring, and we are also including some patients that have been with us from early on, from when we started. Yeah, I think I will not say any more because I'm over time now.
We cannot do everything at once. So
Yeah.
first you had to set up the
So
clinic.
thank you.
I think, thank you, Magnus. Can you please stop the share screen mode so that I can see you? Because I think that you're frozen. So your camera may be frozen. I don't know. I don't have any feedback from the others, but I think that it is frozen. So now you can hear me?
I can hear you. Can you hear me?
Good. I can hear you, right? But I cannot see you.
You cannot see me?
No, I can, okay. Maybe this would work. Thank you. Because we have a lot of questions. What's your experience in Norway? It has a lot to offer to all of us, I think. And are you okay with me asking you questions now?
Absolutely.
Okay. So I have a comment about that still psychiatrists can also medicate you, even if you go, if you have people in the clinic and then those people come out and they may be facing an acute phase or something, or a personal crisis. And then since you do not accept acute, you're not allowed to have acute patients, let's say, and then the system can always put those people back in medication. Is that true? So
yeah,
well, it is only in your clinic that this med-free treatment exists.
Yes, it's only in our clinic or our, the drug-free treatment unit where the goal is to try to give people treatment that do not use psychotropic drugs. So that's something that's only, is the only purpose that we have. But if you go to an ordinary acute ward in the hospital, we have 3 acute wards here, then you will generally be offered psychotropic drugs. But since we are part of the hospital, if there are patients that have a lot that are in our program, first of all, we will often, even if they have an acute episode when they're a part of the program, we will generally take them in, even though we're not supposed to do so. And also, if patients are being admitted to a different ward, they will generally ask us, what shall we do here, if they're a part of our program. And then and so they will generally be less likely to medicate the patients that are in our program if they're also admitted to other wards.
Okay, thank you. And what is your I have this wonderful question. What is the most important experience for you being part of this unit so far?
I think what's made the greatest impression on me is that we have had some patients with very difficult stories, for very long stories that have, really changed their life during the time that we were in contact with them. And that's made a very great impression, just to see these. There are not very many that have this, very big, where it seems to have this very big change. But you have seen some of them. I've seen some of them, and that makes a very great impression. So I think that's important, and I think what's made, really impressed me the most. But then at the same time, I also think it's like I said in some of the last slides. I think it's important that we are. That we get the debate more up, and that it's possible to have some kind of a discussion in the field, because I think often there are when it comes to psychiatry and also to other parts of medicine, I think it's a very in many respects they have traits that are very close to oppression. Or systems of oppression. They're characterized by the tendency to medicate, the tendency to not be able to disagree and not have discussions. So there are very many different traits that are, that you can identify with systems of oppressions that also comes into mental health and medicine as a whole. And one often, say that's because we have this knowledge that we are allowed to, but that's that we can say, what people should do. But that's actually a very authoritarian position to have.
But it is a very common one, and I think that you partly answer another question. Was why are psychiatrists so defensive when people speak about drug-free treatment, and why is this the case? Is this authoritarian?
I think often psychiatrists they have an experience that drugs are useful. I think that, and I think that, so I think generally, I think they think that they do that they do the right thing. And you don't, the way you see things, it's very often seems to be the right thing to do. For instance, we will often, or at times, I worked a lot in acute psychiatry. Our patients will be admitted to the hospital because they have deteriorated or have big problems, and very often that will be connected with the stopping of using drugs. And so the general idea then will be, well, this person stopped using the drugs, that's why she got the problems back again. But when you examine this, which often you will see that the patient got in big problems, and after getting big problems, stopped using the drugs. So the patient may, so there may be many different explanations to this, but there seems to be a general idea, and it seems to be a, this kind of reproduction of, the ideas of this is useful in a way, seems to be, I think, central.
That's true. People ask, is your facility open to visits? If it is, I would like to come, please.
It is open.
Or could you maybe support other organizations, maybe through training or something like that?
We are very open to visits. So that's because we think it's a part of our job is not only to try to give an offer to concrete patients, but a part of our job is also to try to spread the ideas. So that's an important part of the job. So therefore, we think visits is very good. It's difficult for us to take. We have had some people that ask if they can be patients with us from other countries, and that's not possible. It's only possible for people that live in Norway. And most of the patients that we have is, of course, from the northern region, but we have also had some patients from other parts of Norway, because within the public system in Norway, you are supposed to be able to choose to be treated wherever you want to be treated.
So we cannot be a patient in your clinic if we don't live in Norway, but
when you live and work
online?
in Norway, then you can.
Okay,
it's just to live and work in Norway then.
And then how about online treatment? Do you offer?
We have not had any of that. No. And no, and I think what I would like us to develop more is maybe an outpatient part that works with tapering, because we don't have any place like that, and the knowledge about tapering is not good enough amongst colleagues, I think. So it would be good to have a place that kind of gain experience on helping people to taper medication, also other psychotropic medications than neuroleptics, which is what we generally work with, although there are also other drugs that people use and that we help them taper when they're with us.
So people come and stay for how long on average, and then come off completely?
Very often. That's very individual. We have some patients that have stopped taking drugs when they come to us. we have some patients that decide that, well, we want to stop using the drugs very abruptly now. And we have some patients that want to try to follow a more guided slow phase tapering. And when they do that, it will often be tapering that takes somewhere between half a year and 2.5 years. So that's our experience. So we use long time with some patients.
Okay. So thank you very much. I'm really sorry that I cannot see you again, but what you said was very, very interesting and very, very hopeful. And hopefully we can exchange information and knowledge, and there will be some networking through this conference, or from this day on at least.
Very good.
Thank you very much, Magnus, for being here, and it was an honor. And now we're going to have again a break for half an hour before this discussion that we're going to have afterwards, that is focused on what can we do from now on to support withdrawal. Thank you all.
Thank you.
Bye. Bye, Magnus.
Bye. Bye. Lucy, can you see me?
Hi, Magnus. I can't
Hi.
see you. I think it must be your internet connection.
It must be something, because it says here that the camera is on, and you saw me earlier, didn't you?
Yes, it was just the
Okay.
last 10 minutes. I think
Okay,
it
there
was
must
okay
be something with.
because
Yeah,
you know,
okay.
we're all listening. Yeah.
Yeah.
Thank you so much.
But it was possible to see the slides?
Yes, definitely.
Yes, and we could
Very
hear
good.
you.
You could hear me, so that's okay. Very good.
Yeah,
It will be better when we can meet. I look forward to that.
I agree. Thank you,
Thank you
Magnus.
both, Cleo and Lucy. Thank you for all your effort. Thank you so much.
Hello, everybody who's watching this. Just to confirm that we will do the discussion Zoom meeting in 20 minutes. And for those of you who didn't get the link in the chat, you'll receive an email in about 10 minutes with the link and the password. So you just need to look out for that email and then join us in 20 minutes. Thank you so much. Hello to anybody who's still watching. We've just posted the link to the discussion Zoom meeting in the chat, and you should have received an email, 2 emails to be safe, with the link. So I'm going to end this webinar now, and please do log in via Zoom to the discussion meeting, and we'll see you there in a couple of minutes. Thank you.